Good morning. We are going to get ready to begin this awesome program on this snowy day. We said let's do this in November because we won't have snow. Welcome to Looking to 2020 Healthcare and Politics. I'm Dr. Janet Krejci, and I'm very honored to serve as the Dean of this awesome College of Nursing. And also as part of Marquette. Anyone at the game last night? Woohoo! It was a great game. I said we all slept really fast last night. So I'm really glad to welcome you here and tell you a little bit about what you're going to be able to see this morning. The College of Nursing has been graduating the Marquette nurse since 1936, and I know how many of you in the room are a Marquette nurse. Woohoo! All right, wonderful. We take great pride in that because healthcare is fragmented today, and we expect our graduates to be great clinical experts and exquisite technicians and really smart. But we say, if you do not advocate for that human being who comes in with their particular journey, if you do not know them and really live cura personalis, and our tagline at Marquette is be the difference, then we tell the students that they will have not lived up to what we were trying to do. And I say, if you ever let a patient down and you ever decide not to lead, I will track you down and I will haunt you. So we're really thrilled today because one of the things we really want our nurse leaders to do is to understand what's going on in the political arena. So you're in for a treat today. But first, I would like to just give a couple shout-outs to some people. I'd really like to give a special welcome to two very dedicated alumni, Trustee Emeritus Darren Jackson and his wife, Terry. They don't always like these call-outs, so I did ask Terry if I had permission to do that. But Darren and Terry currently serve Marquette as co-chairs of the President's Advisory Council, while Terry, a very proud nursing alum, is also representing the college on the university's National Campaign Executive Committee and our College Leadership Council. So we're really fortunate to have their leadership as we continue to build momentum for the most ambitious, comprehensive fundraising campaign in the university history. So thank you both for joining us and your continued support. Thank you, Darren and Terry. We also have a few other wonderful people you'll hear from. First is University Trustee and College of Nursing alumna Peggy Troy, CEO of Children's Wisconsin. And we're going to hear a little bit more about her and from her in a little bit. I'm also liking to just welcome some of my colleagues, University Leadership Council members who are here, if you could give away, and our provost, Dr. Kimo Ayun. Thank you. Let's now get started. We'll begin with Lisa Grabert, and we are really proud to claim her as a visiting professor of research and health policy in the College of Nursing. Lisa's growing resume of extensive experience in the healthcare policy arena includes serving at CMS, and so those of us in the field know what that is, but that's really who makes all the rules for Medicare and Medicaid. She then went to become the senior policy analyst at the American Hospital Association, and for the 5 years before she came to Marquette, she was on the Ways and Means Committee, and Lisa authored 70 policies that were all written into law, all bipartisan. Last month, she received the prestigious National Award for Bipartisan Leadership, and we're really thrilled to call her our own. So immediately following Lisa, we're going to get additional perspective on healthcare issues for 2020 from Peggy Troy. As you know, Peggy is president and CEO of Children's Hospital. And finally, before we do Q&A, we're going to hear from Dr. Charles Franklin, professor of law and public policy, and I think you are all familiar with the nationally renowned Marquette Law School Poll, which he runs. So welcome to our panelists, and let's begin with Lisa.
Thank you, Janet. Good morning, everyone. The focus of today's session is to explore the intersection of healthcare and political action. These seem like separate and distinct topics, but they are not. political decision-making and policy development drives a significant amount of our healthcare system. It's important to take stock in a few general statistics about what healthcare means in our country. The United States spent $3.5 trillion on healthcare in 2017, or 17.9% of our gross domestic product. 66% of that spending was paid for by the government, which means the majority of policymaking in healthcare is done at the federal and state levels. And that percentage is growing, with every baby boomer in the country being eligible for Medicare within the next decade. Private payers typically follow healthcare trends set by the government. Despite the extensive amount of sheer capital put into our healthcare system, compared to other industrial nations, we don't rank very well. Of the 191 member nations of the World Health Organization, the US ranks 37th, which just barely ranks within the top 20%. Amongst the 35 countries in the Organization for Economic Cooperation and Development, or the OECD, the US ranks below the average for life expectancy at age 65. In a nutshell, we aren't getting what we pay for when it comes to healthcare in this country. We, everyone in this room and everyone in this country, needs to demand more from the healthcare system and the policymaking process. I encourage that. Health policy is always important, but it becomes even more critical as the political climate reaches a tipping point, like this moment in time, less than 1 year before a pivotal presidential election. You've taken an important step towards being the difference in shaping the future of our healthcare system by attending today's session. You are to be commended for being brave enough to talk about tough issues and to engage in the political process. As you engage in the advocacy process, you must remember that politicians and candidates have their own priorities and perspectives on healthcare. You need to engage policymakers who are well aligned with your views, but you also need to craft your message so it is applicable to those who typically take a different viewpoint from you. My work in the federal government has helped me to understand who plays the most dominant roles in setting health policy and how the public can best craft their message to influence those individuals. In my decade of federal policy experience, first in the executive branch and later in the U.S. House of Representatives Ways and Means Committee, I learned some critical lessons, and I have condensed them into 5 discrete points. The first is that legislators want to legislate. They ran for political office because they identified a problem and want to play a role in crafting a solution. They don't think the status quo is adequate. They fundamentally think the system can do better. They are change agents. If your main objective is to protect the status quo, you will be limited in how much you can change. My second big takeaway is follow the money. If you are ever curious why something is the way that it is in our healthcare system, follow the money. If you want to see a different result in our healthcare system, put the money in a different place. My third point is if no one supports your policy, you don't have the right policy. If everyone supports your policy, you don't have the right policy. If you have a healthy number of folks on both sides, you probably have the right policy. You need some groups on your side, but if everyone is on your side, you probably could have achieved more. The goal should be general consensus, not 100% agreement. You can achieve success through compromise, where all parties feel like they can identify something positive about a policy. Not everyone needs to love every single aspect of what you believe in. Number 4, do not underestimate the influence of staff. Of course, this is one of my favorite points because I'm a former staffer. But healthcare policy is immensely complicated. I argue it is the most complicated policy area across all industries. The more complicated a topic, the more time is required to gain an understanding. Politicians are pulled in 100 different directions, and they rely on good staff to help guide their decision making. And the last point that I want to make, which may be the most important point, if you cannot sell your solution to both parties, you don't have anything worth selling. Even the best intended policies go to the graveyard if they are crafted in a partisan fashion. To those people who think bipartisanship is a thing of the past, I say nonsense. As Janet mentioned, I was the lead author of over 70 Medicare policies that were signed into law by both Democratic and Republican presidents. Every single one of those policies was bipartisan. So I want to talk about some more specifics. A policy that I was proud to author that was challenging to get over the finish line is one that I wrote on a specific topic called hospital readmissions. For those less familiar with this topic, the federal Medicare program measures an individual hospital's annual readmission rate across a few key condition areas. This is where a person is discharged from the hospital and gets readmitted within 30 days of the discharge. In its most basic form, the readmission program uses a formula that considers an observed to expected ratio, I am a professor, for each and every hospital in the country. That is how many people we expect to be readmitted within 30 days versus how many people are actually readmitted within 30 days. Each year, a hospital is held to a higher standard of performance, fewer readmissions. If a hospital misses the mark by as few as one single readmission, that hospital could be penalized as much as 3% of its annual Medicare revenue. This could mean an annual loss of millions or tens of millions of dollars for a large healthcare system. Stop and think about that for a moment. That's a lot of money to a healthcare system. This amount of money can and has changed behavior in our healthcare system. Every healthcare system in the country has worked very hard to find new ways to prevent readmissions. But the original policy that was signed into law, like many policies, was not perfect. Early on, the readmissions program began to show signs of serious inequities in the healthcare system. In particular, teaching hospitals, those located in large urban areas, were experiencing large penalties underneath the program at a disproportionate rate. The reason for this had to do with social risk factors of the underlying populations being treated. They were caring for people who were lower income, had fewer resources, and less access to primary care, and overall more likely to be readmitted to a hospital after discharge. Unintended consequences happen all the time with major policy changes, so the government could just change its policy and correct this situation, right? Well, no. Even though the Centers for Medicare and Medicaid Services, CMS, was able to build an adjustment that allowed for more equitable treatment of teaching hospitals, it refused to do it. CMS decided it just wasn't willing to adjust the program to account for social risk factors. Its explanation was that disparities existed, but adjusting the data could mask those disparities and make it more difficult to address the real inequities in our healthcare system. I quickly found myself on the opposite side of the largest health insurance company in the world, and CMS was not backing down on this point. But I stayed the course, and I took on an endeavor to educate members of Congress, one legislator at a time. After a healthy back and forth between the legislative and executive branches, who rarely ever get along, over the course of 4 years, I ultimately prevailed and was able to get a policy that compared hospitals' performance on readmissions to a benchmark of their peers, based on the percentage of patients who were duly eligible in both the Medicare and Medicaid programs. To this day, the policy is the only one in statute for an entitlement program that accounts for social risk factors. The policy is not perfect, and we still have a long way to go, but it was worth the time and effort to pursue a solution that could provide some relief for the Medicare program's most vulnerable beneficiaries. At this point, you may be saying to yourself, sure, it's easy to change national policy when you are staffer on the Ways and Means Committee, but I don't have that role. So how do I make a difference? First, I would argue that you're already making a difference. When you engage in healthcare topics, you are passionate and you are making a difference. When you seek out television, radio, social media, any healthcare topics, you make yourself a more informed individual. But you can't stop there. You need to use all of your knowledge and passion for changes you want to see in our healthcare system. You can make a difference by engaging your lawmakers. First, know who they are. Know their face. If you see them in a crowd, can you pick them out? Call them. Write to them. Visit them in the district. Visit them in Washington. Visit them in Madison. For our out-of-town guests, visit them in your state capital. Follow them on social media. Tag them in your social media posts. In whatever format makes you feel most comfortable, engage them. That is what they're there for. They work for you, the constituent. Now you might be wondering, what am I supposed to say to a policymaker? How do I relate to them in a meaningful way? When it comes to healthcare, Americans are primarily concerned with two things: cost and access. When it comes to cost, almost every American feels they pay too much money out of pocket for healthcare. Whether you receive your coverage from an employer, Medicare, Medicaid, or in the private market, cost is the #1 concern of consumers. Popular topics in Washington right now along this theme are how much consumers are paying for prescription drugs. Another focus of area on policy, referred to as surprise billing. When patients receive a bill for a service they have already received, only to find out after the fact that their service was quote-unquote out of network and they are being charged the full cost. These are two predominant issues right now that voters and consumers are concerned about in the country. On the access front, there's a lot of talk about expansion of Medicare. Whether that means a full-blown public option or Medicare-for-All, or expanding services for vision and dental benefits, policymakers want to talk about these issues. Whether they support these options or they are opposed to them, they still want to have a conversation about them. At this point, I hope to have knocked down almost all the barriers to the advocacy process you may be contemplating. What if you're thinking, okay, I'm ready, but I don't have the means or the time to go to Washington? That's okay. Lots of policymakers are going to be here in Milwaukee next year. They're coming to you. So you have to be ready for them. We are hosting the Democratic National Convention. It's an historic event for the city, the state, and the region. And you guys are going to be ready for all of these lawmakers when they're here in Milwaukee to seize the opportunity to talk to them and influence them on factors that you are passionate about. Wisconsin played a critical role in the last election, and it will play a critical role in the 2020 election as well. When you meet politicians who are here during the convention, and you will meet them, you will bump into people in grocery stores, at gas stations, they will be all over the city. Remind them that you are from Milwaukee or the state of Wisconsin. Talk to them about their experience while they're here. But also remind them when they're having a great time, drinking our beer, eating our cheese, that there are important things that they have to do to protect the interests of the state of Wisconsin and the state of healthcare within our state. So what do I focus on when the members are here next year? I'm going to corner anyone who will listen to me talk about some of the issues that we have right here in Wisconsin. I'm going to mention that within the country, for Medicaid medical education funds that we get, we ranked 50th out of 50 compared to all states in the country. That is not okay. Wisconsin needs to get more federal resources coming into this state. And so when the lawmakers are here and they're enjoying themselves, remind them that they can continue to have fun and enjoy what Wisconsin has to offer if they work to make sure there's equity for every state in the country at the federal level. In addition, we need to make some of those medical education funds available to all professionals. So that's enough from me. Now it's time for you to hear from a real expert, Peggy Troy, who's the CEO of Children's Hospital Wisconsin.
Thank you, Lisa, and I concur with all that you said. You really have, to have her in Washington and writing healthcare policy and actually getting that passed is an amazing feat. So congratulations for all you've done and being that great for us. So as was mentioned, I have the great honor and privilege of working at Children's Hospital of Wisconsin. I do see it as an honor and a privilege, because to be able to work in an amazing organization and be there 100% for kids, I mean, it just doesn't get better from that. And I owe a lot of what I do today because of Marquette University and my phenomenal university education that I was able to receive here through the College of Nursing. And I also want to just shout out several of my advocacy and communication people are sitting up here today, and so much of what I talk about is what they actually do, and we've had some great successes. So I'm going to talk a little bit more specifically about what happens with kids, because kids are often forgotten in healthcare policy conversations, and I'll explain a little bit about that. But I just want to emphasize that what Lisa said is really important. Healthcare policy does dictate a lot about the overall health status of our country, because the decisions that are made in Washington really do affect how we are able to show up. And I'm going to stand here today and tell you that I'm the first one to say that I do think we need some serious change. Unfortunately, we can't necessarily agree on that change today, but this is a topic of conversation. I don't go anywhere in this community talking to an employer, patients and families, whether adults and kids, that say they want to pay more for health care. Nobody's told me that, right? So, and the system was built back in the 60s when Medicare and Medicaid came into the reality, and it's changed much today. And the policies haven't always caught up. The reforms haven't really caught up with where we need to go. But I just want to make that point that, as Lisa said, it's very important that we use our voice. You know, nursing is the #1 most respected profession in the U.S., and it's stayed that way for many years. So for all of you nurses in this room, just don't ever underestimate the power of your voice, because it does really matter. We're seen as caregivers, people who really care about people, have the best interest of people at heart, and so use that voice because it is very impactful. So at Children's, we have a vision. We adopted this in 2010. As we looked around the state of Wisconsin, we said, okay, where are we at with healthcare outcomes, et cetera, et cetera. And if you look at Wisconsin as a whole, healthcare outcome for kids measured about 50 different indicators. We're about the 50th percentile. We're about average in terms of these outcomes for kids. And it's everything from, you know, can they go to school? Can they learn? How's their overall, do they have asthma? Do they have dental care, et cetera, et cetera. When you get to the central city of Milwaukee, we're the 4th worst in the country for health outcomes for kids. Okay, and here we've got this beautiful city. We've got the Democratic National Convention and all Marquette University, Fiserv Forum, all these wonderful things. But the health care for these kids is really abysmal. And there's a few reasons I'll talk about why. The other thing is that we really believe at Children's, because it's true, kids don't vote, all right? So when there's healthcare policy being delivered or debated, most of it is designed around an adult model. And so we have to show up locally, in Madison, in Washington, D.C., frequently, so that we can be that voice for kids and talk about where in health policy there needs to be considerations. And in fact, if you look at the last healthcare reform efforts that were passed a couple years ago, there were about 2 things in there that really refer to kids. And one was they could stay on their parents' insurance until they're 26 years of age, and there was some enhanced reimbursement for pediatricians. But by and large, most of that healthcare reform had nothing to do with kids. There's a reason for that, and kids predominantly end up either in commercially insured because their parents have good insurance, or they end up in the Medicaid program. And I want to make a point about Medicaid. Medicaid's very different than Medicare, and you can't talk about them in the same voice, because Medicare is a countrywide system of care. It crosses all states. Medicaid is a state program that gets federal funding. So every state can, within some parameters, decide how that money gets spent, how it gets used. And so when we look at what happens at Children's Hospital, 50% of our kids are on the Medicaid program. Now, Medicaid's a safety net program, and in the state, we're lucky that it covers kids up to families up to 300% of poverty, which poverty for a family of 4 is about $24,000 a year. So it's really meant to be a safety net program, so that if a kid has if the family does not have adequate insurance or does not have adequate wage to buy insurance, it's there to really protect the kids. Or if a kid's bills are too high, you know, they can spend down the income of the family to make sure that whatever their hospital bills don't make them broke and destitute, so they can't feed and clothe and educate their kids. So while 50% of Medicaid across this country are kids, and the others are blind and elderly adults, disabled people, kids are only 20% of the spend, so they don't spend a lot, particularly if they have great access to health care. And so when we talk about we want the kids of Wisconsin to be the healthiest in the nation, one of the things we care a whole bunch about is the whole notion of access. Because you know, if people have access to health care, they're going to be more likely, particularly with the kid population, to have well baby visits, to go in for their immunizations and all those other things. There's enough data, and I'm sure, Lisa, you know this, and have statistics around this, that if you don't have health insurance, you're going to primarily wait until you're sick, and then you use EDs, and probably it becomes more catastrophic. And so this access point for these kids is really important. As I said, more than 50% of the kids that we see at Children's Hospital are on Medicaid. We also have dental clinics, and 90% of the kids that end up in our dental clinics are on Medicaid. And I can tell you that dental, along with mental care services, are some of the most poorly reimbursed. You might get 15 or 20 cents on the dollar. Why would we do dental clinics? Well, if you believe that overall health is your goal, you can imagine that not having access to dental care is a huge barrier. In fact, it's one of the #1 reasons kids miss school in the U.S. And if you go to get a job, one of the biggest barriers to getting a job is bad teeth. So the implications of that, and then we also know if you don't have good dental care, it leads to other chronic medical conditions because it's unresolved. So that's really important. So we are in Madison and Washington, D.C. frequently talking about Medicaid because remember, 50% of the enrollees are kids, but they only spend 20% of the dollars. And so to try to cut through the voice, and elderly, seniors, disabled vote, and the kids don't. So that voice, how you use your voice is really important. And when we're with policymakers, it's really interesting because I get the opportunity to accompany Michelle and Lindsay on these visits. You know, we go in with, first of all, talking about kids. And, you know, most politicians soften up when you start to really talk about the issue. So we've got sort of a secret sauce in all this. Not with everybody, though. Not with everybody. I'll just tell you that. But we can really start to, we go with a win-win, you know, to really, you can go in there and fight and argue and debate and tell them they're bad people because they're not supporting kids. Or you can go in trying to go with the lens of what the policymakers are facing, what they're worried about, what's on their minds, and really go in with, okay, how do we get to win-win? And I can tell you we've had tremendous success in the state of Wisconsin through, at least in my tenure, 3 different governors to really be able to have those conversations in a meaningful way that have led to some really phenomenal things that we've been able to do for kids as a result of that. So I really think that as you're talking, remember, they've got big jobs, they've got things they need to get done as well. And so if you can frame it within, first of all, what you're trying to accomplish in the best interest of the overall health status of the population, but then do it in a way that it's a win-win solution, you're going to get you'll get their attention in a much more meaningful way. Paul Ryan and I had some very interesting conversations when he was both a congressman and speaker about Medicaid because, as I said, states have an opportunity to dictate some of the rules around Medicaid. And one of the conversations that's happening in Washington and has been over the last few years is really around block granting Medicaid to the states. And so that's basically saying, state, here's the money you're going to get, and you can decide exactly how you want to array and use those services. Well, that money, and so remember, if kids are 50% but only spending 20% and they don't vote, the allocations of resources within those states could be very different state to state. And I can tell you that I was in Tennessee for many years, and giving that money over to some of the states in the lower southern regions, I think would be problematic for kids because their kid policies are already nascent by comparison to other states. So it's a danger in that. We also advocate for kids in meaningful ways in injury prevention. This is a really important concept for us because, again, if you have the vision you want the kids of Wisconsin to be the healthiest in the nation, if they're riding in cars and they're not in car seats, there's a huge opportunity for them to have devastating consequences. So we have really been very active, and now you see, I don't think there's many parents that would ever put their kid in a car today that weren't in a very protected car seat. We also have influenced concussion protocols. If you talk to anybody in the sports arena, concussions are really becoming it's very much recognized now that concussions have serious and devastating consequences long term. And we've seen several kids that are on high school football teams, et cetera, that have suffered from concussions. And in the absence of good concussion protocols, that can follow them into their, and you've read about this, the football players, athletes, the professional teams who have really had really devastating consequences. So we're really active in the concussions. AEDs, which is an assisted device for if a child would have a cardiac problem. About 10 years ago, we started saying, you know what, it's really not many kids suffer from a cardiac arrhythmia or cardiac incident, but when they do, it's often devastating. So what we were able to do is we were able to get AEDs in most of the schools in the state of Wisconsin and train the people on how to use them. So if a child has an untoward cardiac event, there's an intervention right there, and they're going to do well as a result of that. Pulse oximetry tests for kids. Again, these are all policy issues that we think are very important and really need to be legislated because they do help kids in some of these situations where this is totally preventable. Public policy, we've also been very active in that arena as well. In fact, we have an advocacy network, and this has been very powerful in how you use your voice. It's called the Child Advocacy Network. It's an online program. We have 10,000 people enrolled in this now. It's very simple. You can enroll into this advocacy. And so when we know that there's a policy or something happening either in Washington and Madison, we can now spread out through the internet to 10,000 people information, nonpartisan information about what this would mean for kids. And you can imagine if a politician or their staff gets 2, 3, 4, 5,000 emails about a particular issue, they're going to pay attention to that. We've been able to use that very effectively as a way for us to get our voice out there. We've been very successful in a public smoking ban. That happened a lot through advocacy, and again, in restaurants and other places, you don't see people smoking. On another issue that just has surfaced of late, you've all heard about the vaping crisis. Some of you may have heard that Children's Hospital of Wisconsin was the entity through one of our primary care pediatricians who actually put 2 and 2 together. We had about a handful of kids that came in over a 2-week period with serious lung issues. Some of them had to be in the ICU. There was no correlation between because these were healthy kids that were active, athletic, but their lungs were failing miserably. And so we were able to put the research together that we were doing actively as these kids were coming into us, and we were the first ones to call the CDC and say, we think we've got something here. And you've now seen what's happening as a result of that, and now there's been over 2,500 people that have been sick as a result of vaping. The problem is these are young kids, and we do not know yet, the research is not developed, about what kind of implication this has for kids long term. And again, remember, these are healthy, active kids that have the propensity to have a great life, that may have a significant altered lung function that will put them in a very different state. So we're being very active in that arena as well. We're talking to politicians. You're seeing a little bit more, even President Trump a couple weeks ago said, I think we need to have some policy around vaping. They're trying to find what the ingredients are, et cetera, but this is going to stay in the public eye. And again, this is a place where we can have a voice to say, no, this is not acceptable. It's not okay for young kids to be in a devastating state because of stuff that, and the other thing you might not know about vaping is that the nicotine in vaping is more addictive than cigarettes. So it's a big problem. We've got to keep doing on that. We do a lot of research. Lisa talked a little bit about that. It's really important that we know our stuff. When you go in to talk to a politician, you better know what you're talking about. You better have done. So we do a lot of research around policy issues to make sure we're part of a national organization, the Children's Hospital Association. We work with them as well, which is 217 children's hospitals and programs that get together. But again, we do a lot of research before we go in to talk. Then we also advocate for research for kids, because if you look at NIH funding, if you look at the way dollars are used for research and investigation, we get about 1/4 of the money in children. And the thing I like to say to politicians is that, this is a big investment in the future of the country. You all want a workforce who's productive. The only way we have a productive workforce is we have healthy kids that can go to school and learn and really become productive citizens. We've been very active in the foster care and adoption space. This is something that we have a foster care program. We foster care case manage about 3,000 kids in foster care, have an adoption service as well. These are some of the most vulnerable kids that really are, needing loving homes and our services. And so we've been able to very notably affect policy in the state of Wisconsin through the Child Bureau of Welfare to make sure that these kids are well protected. Again, when we show up, we've done our research, we know what we're talking about, and we're reasonable about what we're asking for, because you're not going to win on everything, and you can't get mad. You can be disappointed, but you just can't get too mad. The other thing that we're really active in right now, and I think it's a really critical time, is just the state of mental health and mental health services in our community. I don't go anywhere where somebody doesn't stop me to say, either, how can you help me? I've got a kid, I can't get access, there's no services for them. I've gotten a piece of paper that tells me to get something in the next 6 months, and it's just not acceptable. Even employers are saying, half my workforce has unresolved mental health issues. What can you do to help us? Wisconsin has the highest teen suicide rate in the country, only followed by Washington, D.C. So we've got a serious problem in this state. And what is the situation? We don't have enough providers. Remember I said through Medicaid or even private insurance, the reimbursement for this is paltry, and it's 15 to 20 cents on the dollar. We just had a great success, thanks to Michelle and her team, and Jan Mentz, in getting better reimbursement for mental health services for kids in the state of Wisconsin. So it's a step forward, but we've got many more steps to go on that because we really need to have parity. We want to get kids sooner. This is really, really important. You can diagnose depression in a kid as early as 2. Okay, and we even have an infant mental health clinic that when we know that there's attachment issues that we're seeing, we can put the families into these clinics earlier to get them the access. We're doing depression screening on all kids in our emergency department and our primary care offices that are that are 11 and older. This is a self-reported test that we do in order for them to tell us what's on their mind. I can tell you we found about 100 kids in the last year that were seriously at risk for suicide, and they hadn't talked about it, their parents didn't know it, and we were able to get them into care. But again, we need advocates and partners to talk about this. The stigma against mental health is alarming. If your child has cancer, heart disease, whatever it happens to be, you're going to talk to everybody about it. You're going to tell them, and the outpouring of support, all this other things are going to happen for you. You don't talk about it if your child has a mental or behavioral health issue. Bad parent, bad kid, all the stigma. So we need better advocacy, better policies around this issue so that we can make sure that we're able to do that. We support about 100,000 mental and behavioral health visits a year. That's just scratching the surface. And in fact, we're talking about a policy issue that's very interesting, is if you graduate from a master's degree in psychology with what they call a qualified therapist, you have to work 3,000 hours with no pay, post-master's degree, in order to become certified. Who wants to do that, Who can afford to do that? And so again, we're working with, fortunately we got a very large gift to help us be able to have a living wage and reimburse these people, but we need better policies because it's a huge barrier. It's not that kids don't want to go into this, it's that they can't afford to because the financial burden's too much. Another place that we've had tremendous success is in Sojourner Family Peace Center. And for any of you who know about this, it's a tremendous organization. And it did take a lot of cooperation with public and private organizations to bring this together. And basically what it is, it's a place for families to go when there's been child abuse or neglect in that family's life. And so in the past what happened, this is really interesting, in the past what used to happen is that the kids went one place, the parents went the other place. And so the treatment plans didn't coordinate. So about 10 years ago, John Chisholm from the DA's office and his team came and said, hey, would you ever imagine that you could put all this under one roof and you could get the district attorney's office, you could get law enforcement, child protective services, your care, all under one roof so families have one-stop shopping. And where we were able to make an influence, it was about a $27 million building that's right over here near the Fiserv Forum. And we were fundraising for it, but didn't really have enough to go ahead with the project, and we're able to work with Governor Walker in the state of Wisconsin. We got $10 million from the Building Commission to go ahead, and that's what led us to be able to take care of these families in the most meaningful way. Now, there were Building Commission money is supposed to go for things that influence a whole entire state. We were able to convince them that if we were able to do this in Milwaukee, it would influence our 15 other child abuse centers across the state of Wisconsin in a meaningful way to get better care for these families, so we were able to do that. So anyway, all in all, we are very pragmatic and practical. What I'm trying to show in all of this is that we do have an opportunity to influence. The power of the nurse voice is incredible. And the other secret weapon we have is we go to Washington, D.C. every June with the cutest kid and a family and sit with the politicians and make sure that they hear from the family and the kid what public policy, reimbursement, all these things matter for them, and it works. Thanks.
I'll reinforce all that. Thank you. I'm done. Seriously, those were both terrific points, and all should be listened to. I'm going to talk a little bit about the lobbying side before I get to the public opinion side. I end up doing a fair number of talks for interest groups called legislative days. So whether it's the Hospital Association or AARP or the Roofing Association, they all come to Madison for a morning, they do some conversations, they have to listen to me, and then they walk across the street to the legislature, and they go around and they meet and greet and shake hands and all that. And that's a good thing to do because it shows that you, as a member of an organization, took the time to go and do that, and you go in and typically you speak to your representative or your state senator, and that's all to the good. And I mean, no way am I discouraging that. But I do want to point to the other thing that was mentioned, and that is assuming there's something particular you want to talk about, going to a open office hours that almost every member of Congress and many, if not most, state legislators hold back in the district is worth thinking about. He's now retiring, but Jim Sensenbrenner is one of the longest serving, one of the more powerful members of Congress. Recently, the Journal Sentinel did a story about one of his visits back here, open hours, come meet the congressman. One person showed up. And he and Congressman Sensenbrenner apparently had a fairly lengthy chat about something rather esoteric, as I recall. But that's the point, that sometimes these folks are shockingly accessible. Now, other times you'll go to one and there'll be 50 angry people in the crowd, and probably at that stage, nothing good is going to come of it and you should go home. But I just want to stress that it may seem like these folks are hard to approach or hard to catch their attention, but it's a little easier than you think in a lot of circumstances. And with a little bit of planning and focus on what it is you want to say, and I, because I'm a mild-mannered pollster, would say something that you can present in a positive light rather than I hate you and I'm voting against you and I'm giving money to your opponent might not be the best way to start the conversation. And also to reinforce this notion that they may not agree with you or their ideas of what good policy is may be very different from yours. But the expression that this issue with child health care is a great example is something that I, a constituent who lives in a town which is in your district, this is something that matters a lot to me, and I'm paying attention to what's going on this and what you're doing about it is a really powerful thing. So organize things, 5,000 emails are a good thing, but one handwritten letter almost surely will not be read by the member of Congress, but the staffer will log that into the database and make note of the fact that this was not part of a copy and paste mass mailing of 5,000 emails or whatever. Those are okay, but that extra personal commitment on your part is a big thing. All right, so that was the little pitch on how to lobby these folks effectively. And if you can be a major campaign donor, by all means, go right ahead and do that as well. But you need to hire somebody to do good polling before you do that. So let me know about that. Speaking of polling, my job here is to talk a little bit about public opinion on health care. I'm going to focus on Wisconsin, maybe do a little bit of an aside on the national scene. But we have been consumed with the policies and public opinion, and especially the politics that came out of the Affordable Care Act. That became the defining fault line in American politics from 2010 on, the basis of both state and federal campaigns, and with a chasm in opinion across the parties that really has dominated our conversation. And here in the state, part of that was whether to take the Medicaid expansion, and that's one example of how the ACA affects us here in the state. That's something that's in the hands of state legislators and governors, not a matter of federal legislators. Wisconsin has been a little more sour, a little more negative on the Affordable Care Act than the country as a whole. From 2010, really from the day it passed, ACA was more unpopular than popular with the American public. About 53 to 55% said consistently across many, many polls nationally that they had an unfavorable view of ACA, and about 45%, maybe as low as 42%, said they had a favorable view. That sustained itself into 2016 and towards the end of 2016, only to then dramatically reverse when President Trump took office with a Republican Congress, and you actually saw serious efforts to repeal and or replace. At that point, opinion flipped to be almost the opposite of what it had been. Low 50s have a favorable view of it today. Mid 40s have an unfavorable view. So only a marginal shift took place, but it was a marginal shift that put favorable in the modest majority position that it had not enjoyed since the original passage. Here in Wisconsin, opinion has been a bit more negative, as I said. Typically in our polling, unfavorable would be around 50% or a little bit higher, and favorable would be more like 38, 39, 40, maybe 41 in an individual poll. So a little bit bigger gap, a little bit more negativity. Maybe some of that is because during the time we've polled on it, since 2012 when the Marquette poll started, we've had a Republican governor who's very skeptical of it, combined with the Republican legislature. So there wasn't a majority, a voice in favor of it so much here in the state during that time. We have seen some narrowing of that gap since the Trump administration took over and since the attempt at repeal and replace in 2017, so that now it's moved to about parity, about 48-48 on favorable or unfavorable views. So a little less negative than it was, but still not like the national numbers that have moved to a net of about plus 10 favorable rather than unfavorable. Despite that unfavorable balance, people here in the state have been remarkably unwilling to see it repealed and replaced. So I don't like it, but don't you touch my ACA. I exaggerate slightly. But we've asked different variations on the question, what would you like to see Congress do when it comes to the 2010 health care reform law? Should they keep it as it is, keep the law in place and work to improve it? Should they repeal and replace the law with a Republican-sponsored alternative? Or should they repeal the law and not replace it? Okay, which sort of runs the gamut of opinion or options. We've consistently, since 2013 through 2019, seen roughly 60% in the keep or keep and improve. It's a small percentage, about 6% typically, that say keep it as it is. But then about 53 to 55% say keep it and improve it. In the high 20s, repeal and replace. And below 10% repeal and not replace. So there's a little bit of a paradox here of a law that is a good political object of attack, or at least division between the parties, with one side positive and one negative, but on balance, this real reluctance to repeal and replace, and seeing some reason not to do that. I think that's not entirely irrelevant to the difficulties the President and Congress had when they actually had the majorities to repeal and replace the law that they had voted, whatever it was, 60-something times to repeal, but then couldn't get the job done when it came to them. Public opinion plays a bit of a role here, not, I think, the only role, but an important one. Finally, we asked a simpler question last year. Would you like to see the law remain in place or see it repealed? Just to simplify what the options are. 50% stay in place, 44% repeal. For these reasons, and now the non-public opinion, that when the opportunity came, it became clear that the President and the Republican Party did not have a replacement ready. And so we saw the Congress and the administration struggle to articulate or develop a plan that would be a viable replacement. They also tried to do it quickly. If you think of how long the ACA was debated, that was an extraordinarily long and slow process. I think for those reasons, what you're seeing is, I don't mean this in as negative way as it's going to sound, but it's the trap of ACA, that there's a lot of popular things in it, and it's an incredibly difficult policy area. So to simply wave the magic wand and repeal and not replace, I don't think I have to tell y'all that might introduce some complications along the way. And so it makes it very difficult to think that you have a simple way to replace it. And in those roughly 9 years since it's passed, while there have been really serious efforts in some conservative circles to come up with plausible replacement plans, the fact that when push came to shove, there was no contender that could command a majority, I think is showing how difficult fundamental change would be. I'd also point out, how long was it between Medicare and the Affordable Care Act? If my math is right, it's something like 45 years, give or take a little bit, for implementation and other things. These things are incredibly hard, and ACA got done with a new president elected with a big congressional majority in both houses, and it still only barely got passed. I think the idea that we are going to see another dramatic restructuring of health care policy in the next 45 years or so is probably limited, but that's all the more reason to go talk to your member of Congress or your state legislator and focus on things like a policy change on readmissions. Those are big, important things that don't require a massive restructuring of the entire healthcare system, or focus on children and what can be done to protect them. So that's the sort of public opinion shifts that we've seen. Both polling here and nationally shows that when you drill down to particular elements of the Affordable Care Act, they're quite popular. So coverage of pre-existing conditions became a major issue in the 2018 campaigns here in the state and nationally. And we saw that it was a powerful issue in that campaign, including previous opponents of the ACA rushing to say that they would implement state plans to cover pre-existing conditions. So there's an example. And yet, that campaign largely left out the fact that it was ACA that provided coverage of pre-existing conditions. Most voters don't know any specific provisions of this and have no idea where their particular benefits come from. Coverage of children until they're 26. I have a 20-year-old daughter. I like that provision because I'm pretty sure I'm paying for it till 26. Not to complain about my daughter, but let me tell you some other things she does. So those sorts of things are really important, and people just aren't aware of it. The joke during ACA was keep the government out of my Medicare. And you know, it's easy for us to laugh about that, right? And it is sort of sad in many ways. But it reflects the fact that people want good health care, and they're not at all concerned about the policy details. They're not well informed about those things, and that's a challenge when we talk about these policies. In that sense, 2018 for Democrats and progressives was a real plus because they talked about the outcome, pre-existing conditions, and didn't listen to me with my academic hi-hat saying, you know, you really should tell voters that they have that because of ACA. I actually brought that up with one political campaign manager, and they said, yeah, that's too complicated. We got what we wanted. Voters knew that pre-existing conditions were at stake, and we were for them, and that was the message we needed. We did not want to get it bogged down in which policy, which law provides that. So those are pretty important things. I want to close with Medicare-for-All real quick because that's the new topic. What you see in our polling is a little over 50% say they would like to see Medicare-for-All as a single source of insurance, but we don't drive home the point that it would preclude private insurance. When we ask about a public option that would compete with private insurance, support goes up to about 60%. We haven't asked it, but the Kaiser Family Fund, which does some of the very best polling on healthcare opinion, when they go through specifics like Medicare for All would replace all private insurance, support drops into about 32%. So this is an issue where the specifics are really important. I'll close with this because it just came out this morning. Of members of Congress that ran in 2018 supporting Medicare for All as part of their platform performed worse in the 2018 campaign than those who did not adopt that position. And so we'll see what the presidential race holds for us going forward and where the policy stands. As such a gigantic change in the healthcare system, I predict it will not pass in the next 6 months. Thank you.
Well, I just want to thank our panelists before we start Q&A. You can see why I'm really honored to serve as Dean of the College of Nursing and at Marquette University with these tremendous partners. So let's thank our panelists. Now, I know we all have lots of questions and we could be talking to them for a long time because these are really important issues for all of us. We face these every day in our personal life as well as our professional life. I think one of the things to highlight is when we think of care providers like nurses or the people in places like Children's Wisconsin, you think they're just about providing care, and think about all the work they're doing on policy to make sure that the outcomes can be influenced. So please remember when we're all seeing our providers that they're doing a lot more than giving you direct care, and we got to support them. We have collected questions from the registrants, and so we're going to go through a couple of those questions, and I know that we could be here for a long time, but let's just start. And Peggy, I'm going to start with you, and I think you all have microphones there. You know, those of us who have been working in this industry have always said, well, we're not a healthcare system, right? We are a sickness system. We pay for and we reinforce procedures and diagnosis of disease. And we now have come full circle to say this may not be the best idea. So Peggy, I'd like you to talk about what will it take for the United States to focus its resource on health prevention, because then costs would come down, rather than just reinforcing the model we have.
So that's a great question. And what's happened of late is that there's a lot of evidence and data that's been generated that shows that only about 15 to 20% of health care delivery affects your health outcome. Now, as a healthcare professional, a nurse, that was shocking to me. But when you look at the data, what you find is that the choices you make, the places you live, and your genetic profile really make up the preponderance of your health outcome. And so you have to think about that, because we've been the fixer-upper shop. That's kind of how healthcare evolved. And now it's really about, okay, what are the other factors that influence and affect your health outcome? We call those the social determinants of health. And we know, particularly in kids and it's adults too, if you have stable housing is one of the #1 predictors of a health outcome in people. If you've got stable housing, you've probably got food, you've probably got resources, et cetera, et cetera, et cetera. So as we look at our kids at Children's across our 52 locations, we really take into consideration these other factors, and I'm going to give you a really good concrete example of how this works. So we have an insurance company, a health plan. It's Medicaid only, and we insure about 140,000 people. And in that, mostly kids, in that we also insure pregnant women. Okay, pregnant women who don't have stable housing, don't have access to food, have a huge incidence of premature babies. So in our health plan, when you're managing the risk, right, and you're going to pay the expense, it makes a lot more sense for you to invest on the prevention side than it does having a baby in our neonatal ICU. Now, the irony in that, if you have a baby in the neonatal ICU, the hospitals, from a financial perspective, is going to do better. So you'd say to yourself, well, don't worry about those pregnant women. If all they deliver is preemie babies, then that's fine. You know, well, we know the consequences of that long term for these kids, not only the cost, but long term is. So what we do with these women, and we have about 100 at any given time in our insurance company that are of the most vulnerable. They don't have stable housing, et cetera, et cetera. That person may get a caseworker visit 7 days a week, okay, where we're making sure they have housing, they have food, they have the resources they need to be able to go through their pregnancy successfully. We have about a 90% term delivery rate in the most vulnerable women, because we're taking care of all these other aspects. Yes, we're giving them great medical care, but it's all these other things that really drive the health outcome. In fact, there's a study that shows that social isolation is probably one of the biggest drivers of prematurity. So it's a good example of how we've got to start to back it up. Now, the problem is you don't get paid for that stuff. If you don't get paid for that stuff. So in the reform idea, that's where that really needs to go, is put your money where you're going to get the best outcome, not where it's the most expensive.
Thank you, Peggy. Lisa, I'll go to you now. Charles talked about Medicare-for-All, and given that you've lived the world of legislation, and if this woman can unpack legislation like no one I've ever seen, and has really, I've learned a lot from her, and so have our students. But can you talk about the perspectives of Medicare-for-All and how that might begin to play out in this next election?
Sure. So first, I'll just make a statement that I totally understand why policymakers would be interested in the concept of Medicare for All, because my personal opinion is that Medicare is the greatest entitlement and benefit that we receive as Americans. So people are overall very satisfied with Medicare, and so I understand the notion to gravitate towards it, because I think it's a great benefit that we're offered. So I wanted to share a perspective and a recent conversation that I had with my mother, who is a current Medicare beneficiary. And she was reading the Milwaukee Journal article that came out on Sunday in Sunday's paper that said the annual monthly Part B premium in Medicare is going up $9 in the next calendar year. And she was shocked and appalled.
And she wanted you to fix it.
That the premium was going up by $9. And she really did not appreciate the response that I gave her to her comment. Because I said, Mom, I don't understand why you're upset about that. Because for every dollar you put into the Medicare program, personally, from your payroll taxes, you are receiving $3 in benefit. So if your insurance premium goes up $9, I think you should be grateful, and I think you should have a smile on your face as a result of it. She was not at all happy with that answer. But I think it illustrates that the current Medicare program has some real fiscal challenges and some real sustainability issues. I didn't even lecture her on the fact that get really technical, that the Medicare Part A Trust Fund, which pays for hospital and post-acute care services for the over 65 and disabled population, goes bankrupt in 2026. So we cannot meet the obligations for current beneficiaries in the Medicare program by 2026. So I try to rectify my knowledge of the sustainability of the current program with the desire to expand and add on top of it. And so I have a hard time sort of getting my head around the notion of why that's not what's more focused on and more people are talking about, because that's a pretty serious issue. We can't really sustain the baby boomers that are coming into the program. By 2030, there will be more 65-year-olds in this country than 18-year-olds. That is the first time that has happened in the history of our country. And so we're kind of glossing over real demographic changes that are affecting the program that really kind of compromise the ability to expand it. So to make it a little bit more personal, and I try to grapple this with my former job as well, I was tasked with finding efficiencies in the Medicare program as well. I talked about some of the nice policies I did. I didn't mention that I also cut reimbursement for providers by $35 billion in all the policies that I worked on when I was on the Hill. Those implications to make sure that Medicare could sustain on its current path have real implications. A policy that I wrote for long-term care hospitals in 2013 has closed 40 hospitals countrywide since it's been signed into law. So there are real implications for the current system, and I just encourage lawmakers and policymakers to kind of think about those before they think about expanding to other populations.
Thank you. Just such cheery news for us all, especially us baby boomers, right? But I think, it's really helpful because I think, and I'm going to go back to Charles now, because so many of us have such a superficial understanding of these things. And so how do we begin to be more informed about this? So I will go back to Charles. So you've talked about the ACA and you've talked about pre-existing conditions. Do you think those are the top things that will drive public opinion in this next election?
Yeah, I think because the repeal and replace debate ended the way it did, I'd be surprised to see that come back. But I think where Medicare-for-All and a possible massive single-payer system ends up out of the Democratic primary right now will be an important issue for whether that dominates the fall campaign or whether a more modest keep and improve ACA is the dominant issue. What Lisa was just saying about money, and by the way, if you talk to your mother that way, please don't run for office, because when you tell voters the same thing, even your mother won't vote for you, and the voters sure won't. But here's the thing. Last month, we interviewed voters here in the state and asked a purely open-ended question about what they want out of health care reform now. And there are two things that stood out just from reading through their answers. For the vast majority of them, you would be hard-pressed to guess from their health care answer whether they were a Democrat or a Republican. Because the things that dominate when we give no hint about how to answer this question are, I want my costs to go down because my premiums are too high and my out-of-pocket's too high. I'm concerned about drug prices, and I want to have complete access to every care facility in the country with very low charge to me. That is the exact challenge, though, that legislators face. Is these are big, big bucks. And while I'm sure Children's Hospital would be happy to give up massive amounts of money, that's really not a sustainable answer either. And so, I'm sorry, that was a joke. I want to be clear that that was a joke. But it is the issue that this stuff doesn't come free. And so if you have Medicaid reimbursement rates that are as low as they are, that produces challenges for whether providers can provide them. Look at dental health access as a clear example of that. So we are in a rock and a hard place because the voters, I gave my first talk on this topic in 2006. You know what the biggest concern then was? Cost to me for health care. And so that hasn't changed. And because we as voters don't have to do the math, we're free to complain about the $9 increase. We're not forced to look at the big picture. I think that's a huge pressure on politicians to come up with something that voters would be satisfied with. This is why I think prescription drug costs is probably the low-hanging fruit, because the drug producers have not helped themselves with big increases in some prescriptions, so it's very easy to go after them.
Did you want to add to that?
Well, and I just agree with you because, Amazon and Berkshire Hathaway, they're all trying to, they're coming up with the solution, right? Well, it's been a couple years and they still don't have the solution. It's a very complex question, and matching up people's expectations with how you can deliver what they're asking for in a fiscally responsible way it's tough. Now, I told you in the beginning, I'm the first one to say a lot of this needs to change. There needs to be radical changes, but trying to please the voters plus make it fiscally responsible is going to be a really tough sell. And if it's Medicare for all, I think we could assume that the services we enjoy today are not going to be there in the future.
And I think you're bringing that out that the general public so often wants cost, but they don't understand the unintended consequences that may follow.
And the only change I'll just say is the big change for people right now is that they're in high deductible plans. That wasn't around 10 years ago. And so the burden of the expense of health care for any of you who've been delivered recently has gone up. So the out-of-pocket on individuals' parts is meaningful. And they're not happy about that, but employers are saying it's too much of my overall profitability, so I don't want to spend as much on health care, so I'm going to put more back on the employees to do that. So that's been very problematic.
So I think the last question that several people brought up was, Wisconsin's going to take center stage this summer. We are going to be under the spotlight. And so regardless of political affiliation, we know that healthcare is going to be a major factor. So in closing, what insights would all of you share with us in terms of what opportunity does this present for us, both for the region, all of us, the public, and of course for me, the College of Nursing?
I think it's just to be prepared for delivering your message in a succinct and efficient way when you reach policymakers. You all know what you're passionate about, and you should advocate and pursue the things that make you personally interested in something. And when you're interested in something, a policymaker wants to hear that from you. So take the opportunity when they're here to get your message across. Be ready. Because they're going to be here, and they want to listen to you. They want to learn about Wisconsin when they're here. They want to learn about what our issues are, and they want to talk about health care. Most members do. Most members don't feel totally comfortable talking about it, but they do know that it's important to consumers. They understand cost and access issues. So just talk to them. Just pull them aside and seize the opportunity.
The other thing I would add is, yes, be a voice. We have a tremendous opportunity. And focus on policy and try to stay out of politics, because I think that's the place where you're going to get heard. Policy really is important. I've given you several examples for kids, and so be the voice, but focus on the policy.
Yeah, I'd stick with that and also add the opening line of we need to double spending on something is a difficult opening. The challenges that we have are real. And the money comes with those challenges, but it's not really the opening argument I would want to start with. I just want to say one thing that we haven't talked about, and that's the opposite end of the children, and that's the elder care. and that this is because a certain generation is probably going to continue to age. Not me, I quit aging a couple of years ago, but others are. That this is a special problem in the rural areas of the state where we have declining populations of young people and therefore skyrocketing average age. So you have the combination of rural areas with an aging population and the challenges of delivering care to them where they live and where it may be a 40-minute drive to the nearest facility of any kind. So I think those are challenges. And on the children's side, I'm still struck that I don't think policymakers are as aware as they should be of the changing composition of the under 18 population. And that includes higher rates of poverty, in part due to changing family structures and the concentration of kids in urban areas, but surprisingly, not just urban areas, these changing population characteristics, children in complex family structures and so on, is really a statewide issue. And it further complicates all of the inequities and also the concern that policymakers have, because inequality is absolutely part of the policymaking process. These are weak voices and they're easy to be overlooked. I think the seniors are probably better off because we're old, grouchy, and organized. And you vote. And we vote. Vote helps. Really does vote help.
So finally, people have said, I want to be engaged. I want to find my voice. When I talk to a legislator, I don't know, how should I prepare myself? How can I learn so I can bring in that short conversation beyond my personal story? How can I prepare myself to have these conversations? And I've heard some of you talk about this in the past. Can you just talk a little bit about what advice would you have to all of us to say, as we come up on this election, what are the things when all of us have limited time we can do to be prepared on the issues?
Yeah, so I would just say there's a lot of information out there about lawmakers. You can find out an extensive amount about them before you meet with them. So don't stalk them. But there's a lot that you can find out that gives you a history of where they might be, where they might go, to help you tailor your message so it's best received by the lawmaker. So I had a meeting yesterday with the chief of staff for one of the members of the Wisconsin delegation. And before I met with the meeting, I looked up every single bill that the representative had co-sponsored, because that's publicly available, and I wanted to make sure I understood where that member had introduced healthcare bills and what he found as a priority. And so I said in the meeting, so-and-so has 62 bills that he's co-sponsored, and some of them are on this, that, and the other, but immediately I showed them that I was interested and invested in the process, and I found out a lot about the member and what the member thinks to help tailor my message before I even met with the member. I still haven't met with the member, but there's a lot of information that's out there, so just be really prepared, because it can help you tailor your message so it's best received by the lawmaker.
I totally support what Lisa had to say, because knowing the member, knowing what matters to them, gives you the opportunity to go in with a win-win conversation as opposed to a win-lose. So read, join blogs and networks where they are aligned with what you're feeling, but read both sides of it. You have to be very well informed. I'd invite you to join our Child Advocacy Network, because we do push out a lot of information and we give you a lot of advice, and it's chw.org, CAN. And our secret sauce is bring Q kids. It works every time.
I would reinforce that, but I'll be a little bit of the contrarian. And I certainly think it's good to go in with some idea of the person's background. If you go in and, they're this massive sponsor of Medicare-for-All and you going in with a different message, that's probably a mistake, or vice versa. They're a huge opponent of it. But especially for those of you who may be involved in primary care, I think don't underestimate the power of a good anecdote. There are professional lobbyists who will go in and talk to the members and their staffs about the details of the budget and the consequences of this change or that change. But if you can go in and tell a compelling story about access or treatment or the needs of a patient that you saw, That's the kind of story that might actually lead the member to repeat that anecdote if it's a telling one. And, then leave it to the pros to say, how do we modify subsection 3 of paragraph 4?
Thank you. As we draw to a close this morning, again, the expertise, the wisdom of this panel is phenomenal. And for them to share their time with us so generously, please let us applaud them again. So I want to call out a couple more thank yous, because these kind of events don't happen without a lot of behind-the-scenes work. So I specifically want to call out Pat Schrader, our Director of Strategic Initiatives, who is brilliant at all of this. Thank you, Pat. And Abby Straczynski, who is also our Alumni Engagement Office, and she's done an incredible amount of work, and we wouldn't be here and we wouldn't have this opportunity without the two of you. So thank you. So I think the message to us is find your voice, bring your voice, and get engaged, because there's a lot at stake here. And for us, the kind of gloomy news Lisa said for the baby boomers, we have a voice, let's use it. And I really want to thank all of you for coming. The College of Nursing is very committed not only to preparing the Marquette nurse, but to helping that Marquette nurse be the leaders in society in terms of trying to make a difference for our healthcare system. That is what Marquette University does. It prepares leaders for society. We are tirelessly committed to that, and we really appreciate your support. For those of you who are so inclined, please note that we have some pledge cards on the table. We'd love any support you can offer us so we can continue to prepare the nurse of the future. You, trust me, when you're sick, when you're getting health care, you want to look up and see a Marquette nurse. Thank you very much.